And I really appreciate all of you actually coming in, or logging in from wherever you are. This is a kind of a unique way of spreading education and ideas, and I'm kind of quite keen to see how this pans on. And I wish Dr. Kalyanpur and the Radguru team all the best in this effort. It's really a novel and it's a fantastic way. And I wish I could get all my residents and fellows logging in as well, and I'll certainly look out for that. So anyway, the content of today's talk is going to be based on just generally three broad topics. One is characterization of renal masses. And then we'll talk about staging, more as an adjuvant for pre-operative staging, for planning of treatment, and also for treatment planning. And then we'll also talk about surveillance after treatment, whether it is surgery or even surveillance, after whatever newer therapy that is coming through. So whenever you are given a renal mass on CT or on any modality, the first question you're always asking is it solid or is it cystic? Because cystic masses are so common, or simple cysts are so common, that it is very difficult for us to kind of characterize it unless we kind of know what this is. And one of the ways we do it is by looking at the Hounsfield unit, and this is not an uncommon problem. You have a Hounsfield unit here of 57, which is kind of a dense. So is this really a solid mass, or is this a hemorrhagic mass is the question. And then you look at the post-contrast, and then that is 70. So there is a difference of 13 Hounsfield units. And now, is that an artifactual increase, or what we call pseudo-enhancement, or is that true enhancement? And now, as you know, with all these multi-slice CT scans, the pseudo-enhancement or the incidence of pseudo-enhancement or the degree of pseudo-enhancement is much higher than the older generation scanners, and that has not been quantified yet. So although we have been telling if there is an enhancement of less than 10 Hounsfield units, it is to be considered to be cystic. But we really don't know with the rapidly changing CT technology whether that is still at 10 or it is a little higher. We don't know. And so this is one of the problems that we have. Sometimes you can use other modalities like MRI, where not only can you look at the characteristics here on a T1 weighted image on the left, you can see that this lesion is high signal. And then on the post-contrast, you can see, now you're looking at whether it is enhancing or not. It's most likely not, but then you can always do a subtraction imaging and then see that there is no enhancing component in this, and now you can kind of dismiss this as a cystic lesion without any solid nodular components and move on. Sometimes it's a little bit more difficult, like in this mass here. This is a lesion which was post-RF ablation, and then you are coming into more difficulties. So on MRI, you can kind of use this as a problem-solving tool. As you can see here, it has low signal on T2 and some high signal peripheral areas. And then once you give contrast, you really don't know the extreme right image here. This is a post-contrast image. But then once you do subtraction, then you kind of understand that there is no enhancing component, so you can say that, okay, there is no recurrent disease. So this is a great way of a problem-solving tool. I'm not saying you need to have MRI in all these cases, but in those cases where you're really struggling, you can kind of use this as one of the tools if it is available. The next thing that you come across is this kind of infiltrative lesion. There are two examples here. Now, are both malignant? Are both infections? Now, this is a difficult question. Now, one of them on the left turned out to be pyelonephritis, and it resolved, and the other one turned out to be renal cell carcinoma. The only difference between these two is the presence of retroperitoneal adenopathy. So when you see such a lesion, it can be either or, but then I'll talk about renal cell carcinomas which look like this in later in this presentation. But presence of adenopathy should actually alert you to the possibility of having malignancy as one of the differentials. So how do we characterize renal masses? As I already talked about solid versus cystic, and once you have a cystic lesion, you follow the Bosniak schema, and I'm sure you're aware of it. And I'm not even going to touch upon Bosniak schema because that different talk on its own. So let's go, once we have established that this is a solid lesion, what are we going to do? The first thing you're going to see is this a fat-containing mass or not? If it is a fat-containing mass, for all practical purposes, no matter what you read in the literature, which says there was a fat-containing renal cell carcinoma, but for all practical purposes, if it has macroscopic fat, it is an angiomyolipoma and it is benign. Right. And if you start calling, indeterminate lesion can be renal cell carcinoma, you're creating a lot of hassles for the clinical practice and for the patients. So if you have fat, then that means it is angiomyolipoma. Now then you take about for a solid lesion, what is the size of the lesion? What is the stability? Do we have any old studies? What is the topographic localization? And I'll talk to you about this in a minute. That is a kind of a completely new approach of looking at renal masses. What is the enhancement? Is it homogeneously enhancing? Is it a heterogeneously enhancing mass? What is the degree of enhancement? What does the peak enhancement look like? And if you have MRI, are there other phases, other sequences which can give you some additional information, like signal drop? Does it drop signal on the in and or post phase? What is the signal on T2 weighted imaging? And etc. So these are the things that you're talking about. Now let's talk about size. Now, if you see a solid lesion in a renal, a solid renal lesion, now size is very important because the larger the lesion, the more likely it is going to be malignant. So it has been proven from large retrospective studies that if you have a sub-centimeter lesion, almost 50% of them are going to be benign. So you really don't want to do anything about them. And particularly